Today. Thanks, Sherry, for the introduction. Welcome to our discussion about the BMAT, the new Adult Motor Ability Assessment, which is an overview of the Bruininks Motor Ability Test. Again, my name is Adam Scheller. We'll be here about an hour today, so we're going to be looking mostly at an overview of the BMAT, hopefully be able to answer some of your questions regarding this new assessment. And again, feel free to type any questions you may have in the chat box. I'll try to get to them as best as possible during the assessment today. So basically, we're going to look at a description and overview of the test. We're going to really hit on functional relevance, because this type of assessment, really what's the main purpose of us using this type of assessment, and I think that the functional relevance aspect of the BMAT is really one of its strengths. So I want to talk a little bit about that. We're going to talk about a case report example, looking at some actual case data. And then I'm going to look at some of the development data, including some standardization, reliability, and validity information. The URL that I have listed here on the screen is where you can go to find the BMAT on the Pearson Assessments website. So following today's presentation, please feel free to go look at the website and to look up any additional information about ordering and things like that. All right, so let's get started. First of all, let's look at a quick description of the BMAT and what it is. Of course, we're looking at an assessment here of both fine and gross motor skills, and we're looking at an assessment for adults ages 40 and older. Now, this is an adult adaptation of the younger battery for the Bruininks, which is the BOT2. And for those of you familiar with the BOT2, we're only looking at children ages 4 through young adults 21. Now, the BMAT is a test that can be used by professionals across many different disciplines, including OT, PT, nursing, some human performance assessment, and researchers, physical rehabilitation settings, and other related disciplines. Of course, OTs and PTs and nurses, of course, being those that are most frequently going to use this assessment, but it is an assessment that can be used by many different people. Of course, we're looking at assessing motor abilities related to improvement in physical functioning and/or requirements for ADLs, and of course, that's shooting us back to that functional relevance category that I'm going to talk a little bit more about later. But basically, when we think about the BMAT, it is a very good tool for guiding any of your treatment with older adults, including treatment goals and monitoring progress toward those goals. In terms of its uses, we can think about this assessment being used anytime we need a motor ability assessment for any adult ages 40 or older. But really, there are two primary needs that we think that the test is going to serve most frequently. First of which is living situation placement and support decisions. And those decisions are going to be the ones in which, the decision is really hinged on or placed on whether or not an individual has the ability to perform ADLs independently. And then also the second primary need is going to be looking at treatment planning and evaluation. We also do think that the BMAT is going to be helpful for research on adult motor ability. We do know that it is a reliable and valid measure that's suitable for research. So there are many different options with this type of test, and the options include tailoring test administration in order to target specific motor areas. And that really should prove as a benefit to researchers, just as it is to practitioners. When we look at the BMAT items, the BMAT does consist of 32 items, and there are a combination of tasks that were taken directly from the BOT2. There are also tasks that were adapted from the BOT2, and then there were also newly developed tasks specifically for older adults. So again, for those of you familiar with and who have had some experience in giving the BOT2, you're going to see a lot of very similar types of tasks here, of course, with adult norms. So this should be very helpful and familiar to all of you who are familiar with the BOT2, and the transition to this older adult assessment should be pretty seamless. I do have a wife who is a pediatric occupational therapist, and when she and I looked at this together, she was very familiar with and felt very comfortable with a lot of these items, even though she does not work with older adults. So you'll be able to see that in a lot of the items we talk about. So feel free to chat or throw any questions in the chat box if we come upon an item or a section that doesn't make sense or that you have questions about. So all of the items, also these 32 items, were chosen to meet the needs of professionals who meet the motor abilities, who assess the motor abilities of adults. So what we did in standardization was to really talk to professionals and look at which items in specific or which items specifically would be helpful for you to assess motor abilities in adults. Of course, going back to those primary needs that we talked about, including the living situation decisions and the treatment planning and evaluation. So some additional information that we have about the BMAT is that we do have the ability to get standard scores that are relative to a large population, a sample of motorically healthy adults. So, the standard score idea here is we're looking at the primary standard scores are going to be compared to motorically healthy adults, but we're also able to compare scores to a sample of adults with motor impairments. This is going to be very helpful because not only are we going to be able to determine whether or not an adult's abilities are impaired overall, we're also going to be able to see how much they're impaired. Look at like a level or a degree of impairment compared to others who have an impairment in motor abilities. So that's going to add some additional interpretive analysis on this test that I think is going to be very helpful, and I'm going to get to that as we go along as well. Now, this test can be scored by hand. It also can be scored using the Q Global scoring system, which is our online scoring system. For those of you who are familiar with Q Global, I'm going to be showing some screenshots of the report in printout during our case example later on. But I encourage you, those of you who are not familiar with Q Global, to, again, go to our website and search for Q Global, go to the BMAT website, and you'll be able to access some general brief tutorials that I've done as well for different assessments to be able to see what the system's all about. It is an online scoring assistant, so it's very portable. You can access it from anywhere, and it can be very helpful. It has additional benefits to it as well. So feel free to check that out as well. So again, we're looking here at the test kit. This is what we're going to be getting in the test kit. It does include an admin easel, and that will guide you through the details of all of the test administration. Now, for each test item, the easel does have a dashboard on it, and that also has key information. It has a detailed description of how to administer and score the items, and it also includes verbatim instructions and photos for the examiner and the examinee when appropriate. Now, the test kit does have materials needed to administer, score, and interpret the BMAT, and that includes the manuals, of course, the administration easels, comprehensive and short record forms, because there's a short form to this. We have examinee booklets. There are scoring transparencies. And in this picture, you can also see some of the things I'm going to list, including a stopwatch, red pen, black marker, plastic pennies. Now, there are 50 of them. There's going to be that little red box. There's a penny pad, stringing block set. There's an elbow pad. There are scissors. There are 2 hand grippers included. There's an envelope and sewing board, a tennis ball, and 4 numbered half cones, and there is also a ruler. Now, depending on the subtest that you use, you also may need to provide yourself with things like a tape measure, an armless chair, a stair step, or an exercise step that's about 7 to 8 inches in height, and 2, 4, 5, and 8-pound dumbbells. Now, depending on what subtest you give. Now, if you give the entire test, you're going to need those additional items, but those will be all listed in the administration easels that you're going to need. So please review those before you start going out and giving the test. Just give yourself some familiarity with it, so please review it to determine what you need in addition. Okay, so this is basically a cool little graph that shows us the content and structure of the assessment of the BMAT. We're looking at a total motor composite score at the top here, and that's broken down then into fine motor composite and gross motor composite. But then it's also broken down further into the actual tasks that we're going to be assessing. The total motor composite is made up of fine motor composite coordination subtest and the gross motor composite. Although you can see on this graph here that there's really the coordination subtest only contributes to total motor composite, so there's no other separate composite included. So let's talk a little bit about what's included in each of these tests. So for subtest 1, fine motor integration, there are 7 items, and the items in this test require precise control of finger and hand movements, and they must be integrated with visual stimuli. The items do include things like drawing tasks, using scissors, folding paper, things like that. Now, in terms of manual dexterity, there will be 5 items in the manual dexterity subtest, and they will use things like goal-directed tasks, and that's going to involve reaching, grasping, and bimanual coordination with small objects. Now, those tasks including picking up and transferring plastic pennies, the ones using the small blocks, and completing a sewing-like activity, they're all going to be included in this subtest. They're all going to require manipulatives that are included in the test kit. Okay, now with this subtest in particular, emphasis is placed on accuracy, but the items are timed, and the examinee is told to perform the tasks as quickly as possible. Now, with the inclusion of speed on manual dexterity, the timed activities more precisely differentiate levels of dexterity. So by us including speed, we can differentiate the various levels in how proficient somebody is with manual dexterity. So for subtest 3 under coordination, we're looking at 6 items here, and we're going to be measuring an examinee's ability to coordinate movements of the hand, arms, and feet. For balance and mobility, there are going to be 7 items, and we're evaluating motor control skills that are integral for standing, walking, and using stairs. And for that subtest in particular, we will use a taped course, and that's diagrammed in the easel and in Chapter 2 of your manual, so please review those for this particular subtest. And for the last one, strength and flexibility, there are, again, 7 items included, and we're going to be combining one item that's measuring flexibility of the lower back, and then the other 6 items are measuring the strength and endurance of muscle groups across the body, the legs, torso, arms, and in the hands. Now, this is going to be a benefit. This is going to be one of those benefit points that I talk about throughout the presentation today, but I find this as a benefit and a strength of the assessment as well. There is maximum flexibility in tailoring the testing to a client's individual assessment needs. These subtests that are involved in the BMAT can be used individually, or they can be used in combinations that you as the examiner will desire. The administration times, I can talk a little bit about those, but let's just talk about the various ways that the test can be administered. So involving the total test. So that's administration of all 5 subtests, and it provides the most comprehensive picture of an individual's motor abilities. That's going to take about 55 minutes. Now, that is the preferred option when time permits, because it is the most reliable measure of overall motor proficiency, but of course it's not the only option. So, as I said, 55 minutes on average, and about the middle 80% of testing times range between 39 to 73 minutes. So we're looking at a test that could take a long time, but not necessarily. In the BMAT motor impaired comparison group that I'm going to talk about later, the median administration time was 63 minutes. So you're seeing that with people who have motor impairments, the administration time is going to go up. Now, the other administration option, or the other flexible administration option, is to just give individual subtests. So each of the subtests that are included on the BMAT do include multiple motor tasks, and they have sufficient evidence of reliability and validity to stand on their own, which is really important. Which is a really important factor. So you can also look in the manual to find that evidence of validity and reliability. But one thing I'm going to talk a little bit about later on is that whenever you need to just give one subtest to measure a particular skill, you can do that and feel comfortable knowing that that particular subtest can stand on its own. So each of the subtests takes approximately 8 to 16 minutes, between 8 to 16 minutes to administer, and of course that's going to depend on the examinee, whether or not they have a motor impairment, and of course again on how familiar you are with the test and setting it up and things like that. The other option is subtest combinations, and in this particular option, you can use any subtest that meets your needs and the needs of the client's needs during testing for an individual client. Now, examiners that are interested in just fine motor abilities can choose to administer only the fine motor integration and manual dexterity subtests. And when both of these are administered, the fine motor composite score can be determined in addition to the 2 individual subtest scores. And similarly, when we look at balance and mobility and strength and flexibility, we can get the gross motor composite scores, but then also the individual subtest scores. With the coordination subtest, you're just giving that specific subtest and you're not getting an additional composite score. And with the short form, I do have a little bit listed here, but basically let's look at this in more detail on the next slide. So the short form is the final option of administration. And it is exactly what the name implies. It is a short form, and it only has 10 items. There are 2 items from each of the 5 BMAT subtasks. So it typically takes between 15 to 25 minutes to administer. It is a brief test, of course, like I said, but it is reliable and valid to measure a client's overall motor ability, and it really is a good screening option when you don't need a more in-depth assessment or when it's not possible due to time constraints. So really that's another benefit of this, is to use the short form. You're getting a good snapshot of each of the skills measured. And then, of course, you can use this, and then let's say you find some difficulties when you're doing a screening in fine motor. You can choose to give all of the items from the fine motor subtests, for example, or gross motor. You could give all of the items from the gross motor subtest, or coordination, and so forth. So it really is a great option when you just want to get a snapshot, a screening, or when you don't really have enough time to go through that. And time, of course, is an issue that all of us professionals really have to deal with. So keep that in mind when you want to give the short form. Now, in terms of giving the BMAT, we need to ensure that your client has or meets minimum motor ability requirements, and I have them listed here by subtests. So we need to really be able to confirm prior to administering this that the examinee has, for subtests 1 and 2, which are the fine motor tests, they need to be able to sit at the table and use both hands. For subtest 3, which is the coordination, they'll need to be able to sit in a chair, use both arms and hands, and tap both feet. For subtest 4, which is the I just lost it in my head. Oh, the balance and mobility subtest, I apologize. They need to have the ability to walk without assistance from a device or a person. And for the final subtest, which is flexibility and strength and flexibility, we need someone to be able to sit in a chair, stand, and use both arms and hands. Now, usually these guidelines will dictate when it does and it really doesn't make sense to administer a subtest to a client. But there really are some nuanced situations here that we need to just talk about, some clinical interpretation that needs to be done here. So, for example, now consider a person that has lower body paralysis. A person such as that can attempt all of the items in subtest 1 and 2, but really none of the items in subtest 4. So that really makes decisions regarding those subtests pretty obvious, right? So if somebody has no use of their lower half of their body, we wouldn't be giving them items that require them to use the lower half of their body, so any of the gross motor tests. But subtests 3 and 5, they each include 2 items that require the use of the lower body. So there's foot tapping in subtest 3 and there's standing in subtest 5. So in this situation, the lower body paralysis doesn't really rule out attempting the remaining items in these subtests. So think about that for a second. You may be thinking that we're going to have to give the entire subtest to get valuable information, and that's not always the case. You can give, of course, any items that a person can attempt. You then just can't score the subtest, so that's important to remember. But their performance on the items that they could attempt may be valuable information for you to develop a treatment plan or monitor progress and so forth. So keep that in mind. You're going to need to use some clinical judgment in these situations, but these minimum motor abilities, really, this is a really good guideline to follow as a general rule. So in addition, it's also possible that your client may meet their minimum ability requirements for a subtest, but they might not be able to meet the task demands that are posed by one or more of the items. So it's really important to know that we have to have minimum abilities to perform some of the items, but just because they have those minimum abilities doesn't mean they're going to be able to perform it. The other thing you need to remember here is that you need to be able to, in your judgment, know whether or not it's going to affect their safety. So if an item is going to affect a particular client's safety, skip that item and just mark did not attempt on the record form. So safety concerns really are the greatest for the activities that are in balance and mobility and strength and flexibility. Of course, that's pretty straightforward. All right, let's move on to some of the goals. Any questions, please let me know. If you have any questions, go ahead and feel free to put them in the chat box. But with regard to the test development goals for the development of the BMAT, this is a pretty important assessment going forward. Bruininks, the BOT2, pretty important for young children, and the need really did exist for this type of assessment in older adults as well. So when we were developing this test, or when the development team was putting this together, we really wanted to be able to incorporate a lot of practitioner input, and that's really was done by listening to the needs of professionals like yourself, those who conduct motor abilities with assessments with adults quite frequently. So this assessment process resulted in basically these 4 major test development goals that are shown here. One of the goals of the assessment development was maximum flexibility, as I just mentioned. So it was really designed with that in mind, and really because it can be customized to focus on 1 or 2 specific motor skill areas, or administration can be comprehensive. Also, it's flexible because testing can be performed in as little as 15 minutes with the short form, or as long as 90 minutes with the motor impaired individual taking the entire test. The second goal was national norms. Now, the BMAT was developed to meet the need for standardization with a nationally normed test of adult motor abilities. So there's a very large normative sample for the BMAT, and it was carefully selected to represent the U.S. adult population pretty accurately. And this sample and the development of the BMAT norms, I'm going to describe those a little bit later on in the presentation. When I talk about sensitivity within the impaired range, what I'm talking about here is that although the BMAT was normed using individuals without significant motor impairments, this test really is intended for clinical use. So in order for you to be able to quantify the motor skills of individuals with motor impairments in a way that's going to be helpful to you, the scores that are included in the BMAT have to be sensitive to the ability differences within that impaired range. And this sensitivity is really necessary for at least 2 reasons. The first one is so that the relative strengths and weaknesses can be identified among impaired individuals for whom most or all motor abilities are poor compared to healthy adults. And the second reason is that as the ability changes, which really is typically those improvements that are resulting from treatment, we can detect those changes within that impaired range. You know that sometimes we get very small incremental changes, but we need to be able to determine or detect those changes from treatment. So that's really why we needed to have a lot of sensitivity within that impaired range. So let me talk a little bit about this more in depth, which is, the BMAT was designed to have 2 features, basically, that ensure that we can have good score differentiation within the impaired range. The first feature is that the items were developed to be sensitive to differences in ability among impaired individuals. So with that, most items can also be attempted by individuals with very limited motor skills. So we can make sure that we're not leaving out many people with impairments. And then the second design feature is that the BMAT does use a standard score scale with a mean of 500 and a standard deviation of 20. And that means we're able to use that standard score and it's sensitive to ability differences and changes among very highly impaired individuals on all subtests for all age groups. All right. Now the last test development goal that I've listed here, which is the functional relevance area, is that we're going to get into that more now, because I think that's really, like I said, I think that's really one of the benefits of the BMAT. But the BMAT items are not just samples of actual activities of daily living, but they do measure component motor skills that enable or prevent the performance of ADLs. So let's look a little bit more at this functional relevance issue here. Let me talk a little bit more about that as we go along. During the pilot phase of the test development, examiners that were administering the BMAT, they completed a feedback form, and it asked basically several questions about each test item. One question asked examiners to rate the extent to which performance on the item appeared to be related to the ability to perform ADLs. Excuse me. Then the item selection for the final test was based partly on those ratings. Another question asked examiners to nominate for each of the items specific ADLs that they thought were related to performance on the items. So when this was given during the pilot test phase, we were really looking at what items contributed to what ADLs. So let's look at the charts to go over this a little bit more. So when we're looking at fine motor integration, okay, for subtest 1, individuals were seen as related. Were seen as these items relating to ADLs such as reading a map, differentiating coins, folding laundry, and cutting scissors. So if we look, let me get one of my little arrows here. If we look at filling in a circle, we see that item 1 was found to be related to writing, to dressing, to using feeding and grooming tools. We also see some commonalities between some of these items. So the ADLs measured with 2 and 3, which is drawing a line through a crooked and curved path, also can be related to writing, to dressing, feeding again, and this was also using a map. When we're looking at copying a shape, the ADLs related are writing, copying, and grooming. With marking shapes, we see writing again. We see writing a few times here. Then we also add things like scanning a page for information, differentiating coins. We see recreational activities here as well, and dressing. Folding paper, of course, you can think of that being related to office tasks. Again, dressing, bathing, and folding laundry. And then cutting out a shape was seen as related to cutting with scissors, using implements, and so forth. So when we move on to subtest 2, which is manual dexterity, we see that the items included in manual dexterity are also, again, we're looking at very fine motor-oriented tasks, but handling small objects, dressing again, but we're looking at fastening and buttoning here specifically, and also food preparation. With the transferring pennies in the both hands simultaneously, we're adding things like additional kitchen tasks. The stringing of blocks, of course, sewing and dressing, and also sewing with a sewing board, of course looking at sewing and dressing. When we move on to coordination, I just wanted to mention, too, when you look at tasks like this, even with manual dexterity, right, you start to think about how these ADLs, so when somebody's performance on a task like transferring pennies, may affect your ability or your decision when we're talking about placement, or whether or not somebody can live independently. Can they dress daily? Can they prepare their own food? Can they prepare their own pills if necessary during the day? And certain items that you're going to be looking at will help you make those decisions. So you're able to see a lot of very specific functional relevance, which is really going to be helpful for you. So with coordination, let's look a little bit more at each of the subtests. With coordination, we're looking again at the ability to dress, bathe, and groom. We add driving to tapping feet and fingers. Of course, that really makes a lot of sense. Looking at catching falling items or sports activities with catching a ball, play activities again, sports activities, leisure activities with tossing a ball. So each of the coordination subtests involve specific skills that are related to the ADLs listed on the right there. When we're looking at balance and mobility, we start to look at things like just basic gross motor safety issues like standing, walking, dressing. Are we going to be able to allow a patient of ours to go home and shower by themselves? Are they going to be able to stand in the shower by themselves without danger? Are they going to be able to dress or even get in and out of bed at night? So these specific items we're looking at for balance and mobility are going to help us determine this. Walking forward on a line, specifically tight spaces given the outlay or the layout of a person's home. Can a person balance while dressing, or do they need a specific implement to be able to help them dress while sitting? Of course, getting in and out of a bathtub. We're looking at even just walking, maneuvering in tight spaces with lateral step on a line. Up and down stepping, pretty straightforward, of course. If someone has steps in their home, this is going to be an item that we're going to want to be measuring. And then again, walking in alternating directions, looking about walking around safely in their own homes. And when we look at the final subtest here, which is strength and flexibility, this adds additional items, such as can a person rise from their bed, rise from a chair, tub or shower, bench or toilet? Can they push their own shopping cart around? We need to see whether or not, if we go up to see the front shoulder raises, again, we're looking at lifting objects, but it's also related to dressing. Seated bicep curls, doing laundry and other housework, carrying groceries, just basic sitting and standing, of course, is pretty straightforward, right? When we look at grip strength, can they open their own containers? Can they hold on to cans or shopping bags? What other types of adaptive implements can we put into place? Flexibility, we're looking at washing their lower extremities. Do they need to use a shower, like a stick or something, like a rod or something, where they can actually have something attached to the bottom to help wash their lower extremities? Can they pick up items from the floor and stuff, and so forth? So the reason why I wanted to go over those, and I know I went over them pretty quickly, but the reason why I wanted to go over those, again, I mentioned, is because you can look at each of the specific items that you're giving and then refer to the charts that are in the manual and determine which specific ADLs can be affected by those skills. So this is really going to be able to help us drive the treatment planning and drive where we're going in terms of adaptations or goals, and what specifically we're going to be addressing. What accommodations do we need to put into place, or what types of decisions can we make in terms of independent living. All right, so what I'm going to do is, hopefully everybody is following along okay. I'm going to actually share my desktop to this specific, wait, I'm sorry, I apologize, I should have been there already. I'm going to share my desktop to show you all the PowerPoint presentation, because, you know, like I like to do sometimes, I put some animations in here and they didn't work in the program that I just had up. So let's talk a little bit about our case report example, and I'm going to be showing you specifically we're going to specifically go through each of the items on the record form and then talk about the report example. So what I'd like to do is start here with Mary. She is a female, 79 years of age, and we tested her on, this was tested in November of last year. She was righty, preferring right hand for throwing, drawing, and also with her foot and leg, and we used the female norms for comparison. Okay, so when we go forward, here is the fine motor integration test. So for filling in a circle, Mary was not able to do any of them. She was not able to fill in a circle at all, which would correspond, as you see on the record form here, to hold on, let me pull up a highlighter. Okay. As you see here on the record form, it corresponds, the raw score of 0 corresponds to a point score of 0 as well. So we just put that in the side over here. Now, for drawing a line through a path crooked, Mary was able to do it with only 3 errors. Well, 3 is a lot of errors, actually, which corresponds to a point score of 4. With drawing a line through a path that was curved, she again had 4 errors, which corresponds to a point score of 3. With copying a shape, she was able to have 5 points here. And again, I apologize, I don't have it listed here, but basically what she was able to do was she got a 1 point for basic shape, closure, edges, orientation. She had a little bit of separation, so she had a 0 there, and the overall size was okay. So that's a score of 5 points, which corresponds to, of course, point score of 5 as well. In terms of marking shapes, she was able to mark shapes on the first trial in 22 seconds, in the second trial in 26 seconds. So she was able to score 22 seconds, corresponds to a point score of 4. When we're looking at folding paper, she was able to earn 3 points total, which, again, she was able to get 1 and then 2, and then no on the envelope. So basically that corresponds to a point score of 3. And then cutting out a shape, she was able to cut out a shape actually pretty well. Achieved point scores of 3 on each of the segments. So that corresponds to a raw score of 12 and points of 7. When basically all we do then is add those all together, put them down at the bottom, and out of a maximum, as you see down here at the bottom, of 44 points, Mary was able to get 26 points. Now, when we look at the manual dexterity subtest, we're looking at, again here, make sure that whenever you see these little notations, you follow them for the specific subtest, because they are different. So for Subtest 2 manual dexterity, you're always going to conduct a second trial. And as you see here, each trial is 15 seconds. That will also be listed here on the record form as well. So for the first one, transferring pennies, in 15 seconds, Mary was able to do 5 the first trial and 6 the second trial, which only corresponds to a point score of 1. For using both hands simultaneously, she was only able to do 4 in 15 seconds each trial, and that's a 0. For stringing blocks with her preferred hand, she was able to do 2, then 4, which corresponds to a point score of 4. And then for stringing blocks in the non-preferred hand, she was able to do 2, then 3. Sewing with the sewing board, she was able to complete the first trial in 44 seconds and the second trial in 42.4 seconds for a point score of 5. Total score was 13 out of 45. So hopefully I want you to start thinking as we go through this case example of what exactly we're seeing here. Hopefully you've started to see, as I have, that Mary has some difficulty with fine motor skills. All right, so let's look at the coordination subtest. Again, look at the notation that's up here at the top. So for items 1 and 2, we're only going to conduct a second trial if and only if the examinee does not earn the maximum raw score in the first trial. So what we're looking for is a maximum raw score of 10 on trial 1 here, and a maximum raw score, again, of 10 on item 2. So Mary was able to do 10, basically touch her nose with her index fingers with her eyes closed on the first trial, so we don't have to administer the second trial. Again, she was able to tap feet and fingers on the same side synchronized 10 times, so we don't administer trial 2 either. In terms of dropping and catching a ball with both hands, she was able to do that 3 times. She was able to catch a toss ball with both hands only once. Catch a ball with one hand, she was not able to do that at all. And she was able to toss a ball 4 times for a maximum score, or for a score of 16 out of a possible 28. Let's move on to subtest 4, which is balance and mobility. So again, look at the top up here for items 1 through 6. We will conduct the second trial if the examinee does not earn the maximum raw score on the first trial. So again, we're looking here at, I apologize. Again, we're looking here at 10-second trials, as you can see here listed on the left. So for standing with the feet apart on a line with the eyes open, Mary was able to do that for 10 seconds, so we did not need to attempt trial 2. For doing the same task with her eyes closed, she was only able to stand for the first one for 4 seconds and the second one for 8 seconds in the second trial. So that corresponds to a score of 3. She was able to walk forward 8 steps on a line. The first trial, she was able to stand on one leg on a line with her eyes open for only 1.5 seconds and 2.1 seconds in the second trial. So that only corresponds to a score of 2. She was able to make 16 lateral steps on a line, walk up and down stairs for 8 sequences, and walk in alternating directions for 25 seconds. So this is a test where you're starting to see some variability of skill, or I'm starting to see some variability of skill. So when I start to think about this, I'm starting to think that particularly standing on one leg is difficult for Mary. So keep that in mind as we go along and start to look at the scores. That's 25 out of 29 points. So even though, even though the overall test, overall subtest she did pretty well, 25 out of 29. The standing on one leg is going to be difficult for her. So when we look at the fifth and final subtest, strength flexibility, again, for item 1, we're going to conduct the second and third trial if and only if Mary did not earn the maximum score of 12 inches on the first or second trial. So we're looking at the sitting flexibility here. Again, Mary could not do 12 inches on either of the trials. And now that I think about it, I wonder if I could do 12 as well. But that's neither here nor there. But for trial 1, we had 10 inches, then 11 and 11 on the subsequent trials for a score of 4. Now, in terms of grip strength with her preferred hand, she was able to do 25 closures in 30 seconds with her non-preferred hand, 22 closures in 30 seconds. She was able to sit and stand 11 times in 30 seconds. She was able to do seated bicep curls 3 times, only 1 front shoulder raise, and 4 wall push-ups. So again, we're starting to see some variability here in her test performance as well. Some of her strength, some of the strength activities are a difficulty for her. So overall, she did pretty poorly with 24 out of 59, but we see some scores here that are a little bit more concerning than others. Okay, so let's look at the record form. Let's look at what these scores mean and how we interpret them over or across the test. So in terms of the record form, this is what you're going to be using if you want to do the hand scoring. I have the tables circled in red up at the top, so I'm not going to go over the hand scoring because I think that's pretty straightforward. That's a pretty easy task to do. You just go to those tables and convert the scores. But basically, I wanted to show you what tables you're going to reference when you're transferring the scores here. So what you'll do is write all the total point scores for each of the tests, each of the subtests on the front of the record form, and then if you're using that, go ahead to the tables. If not, just put them in the Q Global scoring system, and it will report all or compute all the scores for you. So let's go over this this first sheet here. As you saw, the point score for fine motor integration was 26, and that corresponds to a standard score of 421. Now, we know that, again, 500 is the mean and 20 is the standard deviation. So we're seeing here that this Mary had a great difficulty with this test, a percentile rank of 1. Again, the same is true for manual dexterity with a point score total of 13. That corresponds to a standard score of 377, with 361 to 393 being the 90% confidence interval, and that corresponds to less than the first percentile. And of course, we're looking at the percentile rank compared to motorically healthy adults here, okay? So compared to motorically healthy adults, her fine motor abilities are below the first percentile, which means that we know that she's having a real difficult time with fine motor tasks. In terms of coordination, a standard score of 444 with 427 to 461 for 90% confidence interval corresponds to the second percentile for motorically healthy adults. But if you remember correctly, we're going to look at this more in a little bit, that the coordination subtest, there was a lot of variability there. So we're going to start to see how that plays out. Now for balance and mobility, her standard score was 502, which is just at about the 50th percentile. In terms, it is at the mean, so it is compared to the 44th percentile for her age compared to motorically healthy adults, and that is a standard score range of 488 to 516. For strength and flexibility, we're looking at a standard score of 445. Again, she's having difficulty with a lot of the strength exercises, and that's only corresponding to the first percentile. But we see a gross motor composite here of 467 at the 8th percentile. I would less, when I see this, I would less interpret this composite score just because we see a lot of variability between balance and mobility and the strength flexibility components. But I would probably talk a little bit more about the strengths and weaknesses between each of those subtests. When we're looking overall, her overall standard score of 411 is again below the first percentile. So we're looking at Mary, 79 years old. We do see a lot of pretty significant motor issues with Mary. I like this printout. I like this page a lot. It gives us some good information. Let me talk a little bit about what we're looking at here. This is again a printout from when you use the online scoring system. This shows us the corresponding the standard score relation to the ranges that are obtained by in the motor impaired comparison group. So the red line over here on the side, on the right hand side of each of the scores, shows the percentage. Basically, this is the lowest 25%, the lowest scoring 50%, the lowest scoring 75%, and the lowest scoring 90% of the individuals in the motor impaired comparison group. So this really helps us start to differentiate performance, right? So Yes. Does Mary have deficits compared to motorically healthy adults? Yes. We saw that in the last page. We were able to use the standard scores to make that determination. But level of impairment and treatment progress on treatment goals or treatment progress toward using interventions, this analysis will really help us make those decisions a little bit more accurately. So for Mary, the 421 standard score for fine motor integration corresponds to just about the 25th percentile of motorically impaired, the motor impairment group. When we're looking at the 377 in motor dexterity, that's, I can't give you a number here, but that's even well below the 25th, the lowest scoring 25th percent. So we're looking even probably less than 10% of the motor impaired group. When we see the 444 for coordination, we're just a little bit above the 25th percent. The 502 for balance and mobility, while I probably wouldn't be as concerned about the subtest anyway, this is just right around the 75th to 80th percentile. When we're looking at 445 for strength and flexibility, we do see then, again, this is just about the lowest scoring 50th percentile for the motor impaired group. When we look at the composite scores, we do see some real differences here. We see that, Mary's fine motor skills are a good bit lower than her gross motor skills. But let's look at this in a little bit more detail, see if we can start to really tease this out. This is, again, the pairwise comparison chart from the Q Global scoring system that we're going to be looking at. The reason I can make the determination that her gross motor skills are better than her fine motor skills is by this comparison. We're comparing fine motor composite to gross motor composite, and that 76-point difference in the scores is significant at the 0.01 level, but it's also very rare. So when we look at the frequency of difference here, that only happens in less than 1% of the population or in the norm sample. So we know that level of that level of difference between those two composites is not only statistically significant but also clinically significant. So I would start to think about tailoring our treatment toward fine motor skills. We see that's a significant weakness. So when we move on to looking at subtest comparisons, we're also able to think about what specifically between the subtests we would be most concerned about. So for this first one here, we see that manual dexterity is significant. Her manual dexterity score is significantly lower than her fine motor integration score. So even though fine motor skills are a weakness or fine motor skills overall are a weakness for Mary, her manual dexterity scores or skills are even lower, are much lower than her fine motor integration skills. So 44 points is, again, both statistically significant and clinically significant. In psychology, the general rule of thumb is anywhere between 10 and 15% frequency is considered, or lower, is considered clinically significant. So I am not 100% sure, but I'm almost about 98% sure that the same guidelines are used in other fields as well. But if you have other guidelines that you use, please feel free to put those in the chat box. I'd love to hear some of your feedback. But generally, we're looking at anywhere between 10 to 15% and below, looking at that as a clinically significant difference. Again, the next subtest we see here is the difference between fine motor integration and balance and mobility. We see that fine motor integration is a weakness for her. Again, we're seeing motor dexterity showing up. Against all subtests, manual dexterity is a significant weakness. When we look at coordination, though, however, coordination, when we're comparing that to balance and mobility, can be considered a significant weakness. We see that a 55-point difference being, again, both clinically and statistically significant. The difference between coordination and strength and flexibility is not significant, and either it's not significant statistically, and it's not infrequent. So we wouldn't even think about comparing that in this chart. And you see that again here as well for these comparisons as well as these comparisons. And then also when we compare balance and mobility to strength and flexibility, which are the two, of course, gross motor subtests, we see that her strength and flexibility are significantly lower than her balance and mobility. So looking at this type of a chart really starts to help us develop treatment plans, right? Develop interventions or goals, or what do we want to address. We see that manual dexterity is a significant weakness for her. We see that there are probably some areas in coordination we want to address, as well as strength and flexibility. Okay, so let's move on and see what that looks like. I apologize, I forgot this was in here. This is just a narrative report example. This is the beginning of the narrative report that we see that comes out with Q Global. Again, this is a report that comes out. It talks about each of all of the scores across the test. Best practice is not to just print this out, sign it, and hand it in as your report, because you really want to be able to integrate findings within your report and your overall interpretation and impressions. But it is available for you to be able to look at if you use Q Global. All right, so let's talk about some of the conclusions for Mary. As we talked about, general areas of weakness we saw for her were in manual dexterity and strength and flexibility. We do see a general area of strength being in her balance and mobility. So she's able to move around okay and balance fine, but she has some difficulty with strength activities as well as the manual dexterity. But how much information does that give us? It gives us good information. I'll tell you, it gives me a lot of good information. But I want to start thinking about the specific areas of need. So let's look at each of the ADL related these charts that I talked about a little bit before. These are all the ADLs related to the skills involved in the items. So what I did basically was I took the charts and I went back and I looked at Mary's performance on each of the items and what did she have difficulty with specifically, so we can really start to think of the ADLs that are going to be affected. So we know that items 1, 2, 3, and 6 were particular weaknesses for her, which would then start to get me concerned about her ability to her writing, her dressing, using feeding and grooming utensils. Again, we see that again here. Also, see that dressing, bathing, possibly folding laundry, and then other general office tasks could be affected. We did see a strength here with cutting out a shape. Again, it's just one particular task, but those maybe, of course, we develop treatment plans based on strengths, right? So maybe these are some strength activities that we can integrate into her treatment planning. When we look at manual dexterity, we did only see items that were relative weaknesses for her. So again, anything talking about using small items, but also then dressing would be a particular weakness for her. Any types of fastening, buttoning, or zipping, lacing and tying shoes would be a difficulty for her. If we knew that she took pills, that would start to concern me whether or not she'd be able to do the pills correctly. So we start to think that these are particular weaknesses for her based on her performance on the items. We're looking at coordination. I see here that she was able to touch her nose and tap her feet and fingers, and those are particular relative strengths of hers. But then weaknesses with the tossing a ball, with catching balls, would then get me concerned about some of the play activities, whether or not she can engage in play activities or sports, but then also dressing and bathing as well. And then when we look at balance and mobility, we only see strengths. I see her as having a lot of strength there. But for strength and flexibility, we do see, again, related weaknesses with the strength of biceps, front shoulders, and wall push-ups. So these charts that I have listed here, the reason I did that, and it's a practice that you can do as well, is to just go through and start thinking about the ADLs that are going to be affected by the weaknesses that you're seeing in her performance. So, this is an additional level of interpretation that goes beyond just determining impairment. We're actually looking at treatment planning here. Okay, so quickly, I have a couple minutes left. Let's talk a little bit about the some of the standardization, reliability, and validity. Again, we do have the norm group here that is basically meeting two criteria. They live independently in their own home without requiring assistance from a paid or unpaid caregiver, and they have no known motor impairments. Now, adults in this sample could have mild arthritis if it didn't impair their motor functioning. And then also they had to be able to speak and understand English, have normal vision with or without corrective aids, and not be taking medications that impact motor ability. Okay? So again, you see here it's a pretty large sample, 1,000 adults, 500 female and 500 male. With the motor impaired group, this is basically what the motor impaired subgroup looked like. Basically, we're saying these are adults that were not able to live independently. They were living in one of three living situations. The first one was staying in an assisted living, skilled nursing, or rehab facility, or living with a caregiver, or living in their own home with somebody visiting at least 5 days a week to provide assistance. So we're looking at somebody that really does need a lot of assistance in their living situation. In addition, we're looking at people who have a generalized motor impairment affecting both gross and fine motor here. They did have to have the ability to walk without assistance during testing, even if preferring to use a cane or walker. Okay, they had to be English speaking and again have normal vision with or without corrective aids. So you do see here that there were 82 individuals met that criteria. 2/3 female and 1/3 male. There were many in their 70s, 80s, and 90s, but there were quite a few younger here as well. Almost half of these folks were staying in assisted living with fewer than 20% each in each of the other four living situations that I talked about. Okay. In terms of cognitive impairment, the other important point about this is, in terms of cognitive impairment, most sample members were rated as having either no impairment or mildly severe impairment. I see that we're running out of time, but let me just go through quickly some of the additional reliability and validity information. This is just showing us that the test-retest reliability is very high here. Generally, reliability coefficients that are 7.70 and below are poor. Between 0.7 and 0.79 are fair. 0.8 to 0.9 are good. 0.89 are good, and 0.9 and above are excellent. Now, based on that criteria, the test-retest reliability of the fine motor integration subtest is fair, and the reliability of all of the other scores is good to excellent. And that really does indicate that the occasion of testing does not really have a pronounced effect on the BMAT scores. In terms of Interscorer Reliability, the adjusted correlations are really considered the best indicators, best reliability indicators, and all of the adjusted Interscorer reliability coefficients in this table approach a perfect 1.0. And really that means that the different scores provided almost identical item scores, which resulted in almost identical scores across subtests, composites, and the short form. In terms of validity, this is another good little discussion that I'll talk about for another minute, which is that basically we're looking at here, I want to hit on the demographic trends since we're running out of time, but the demographics trends example that I'm showing you here, you can see how the performance of the norm group declines as the age increases, and that's really important. This example here is for manual dexterity, and that shows that there's a steady decline in test performance with age. And that's what we'd expect, right? So as a person's age increases, their performance on the test items should decrease. So we can see here for the BMAT manual dexterity subtest, we see that trend also it follows suit for this subtest, which is what we'd expect. So really, this is a show of validity. It's showing us that we can feel confident that that the scores are going to decrease with a person's age. Okay, and then we're going to see that reflected across all subtests. So you can see that here as well for the balance and mobility and the strength and flexibility subtest. We do see that there's a general decrease across age with the norm sample. In terms of clinical utility, we see that we are able to differentiate effectively between two groups, the motor impaired group and the non-motor impaired group. So basically, the effect size means basically what we're doing is we're comparing the two groups using effect size here. What it means is that we're describing the effect of being in one group versus the other. So 0.8 and above are considered greater, are considered large effect sizes. So we're really able to very easily differentiate between motor impairment and non-motor impairment using this test. Convergent validity basically showing us that the items on the test correspond to other tests that we know measuring similar tasks. Oh, okay, and this is the end then. Since we're over by a couple of minutes, I kind of went quickly through that last little part. Hopefully everybody was able to follow along during the entire session today. I'm glad that you were able to participate, and I'm putting my information up here at the end for anybody that wants to contact me directly. My information is at the top. Visiting our website to look for further information about the BMAT, and calling either our customer service in the USA or Canada for more information. Thanks again for coming, and I will stay on for a couple more minutes to see if anybody has any additional questions. Thanks again, and have a great day.
Thank you. Please stand by.